Hi, everyone, and welcome to our Frankly Speaking About Cancer Risks Among African Americans. My name is Kelly Kraft. I am Program Manager at Gilda's Club Quad Cities, and I am here with Dr. Jager, and I will let her introduce herself.
Hi, everybody. I'm Dr. Jager. I work at Iowa Cancer Specialist. I'm actually a family practice trained physician that works with Dr. Friemel. Gilda's Club has asked me to do this presentation on cancer and African Americans, and I'm delighted to be here today, and thanks for joining us. So do you want to go ahead and start the slideshow, and we'll kind of go through what we've got to cover tonight?
Sure thing.
Okay, so what we're going to be talking about is there are some differences in cancer risk among African Americans. And so we're going to present some information about that. We're also going to talk a little bit about signs and symptoms of the most common cancers, and then also some risk factors and ways to decrease your risk factors. So go ahead to the next slide. And this is who prepared this slideshow for us. And we're going to cover the most common cancers, both in men and women. So they're going to be broken up that way, signs and symptoms. We're also going to talk about types of screening and different tests that we do to identify cancer, and then also developing an action plan. And this program was developed by the cancer support community. They are independent and outside medical, and they have both medical and psychosocial experts that reviewed it. And the presentation was engaged by the Gilda's Club. So why is this important? Well, because there are quite a few, as you see the number there, new cases of cancer that are being diagnosed in African Americans. And this data is from 2019. And the most common cancer diagnosis among Black men are prostate, lung, and colon and rectal cancer. You'll see prostate's quite high, with 30% of all cancers in men. That's not too uncommon from Caucasians as well. And then women, again, most common cancers are breast with 32%, lung 11%, and colorectal 9% of all cancers. This is a little bit busier of a slide, and you'll see at the top, it's talking about numbers of estimated new cancers, and it's dividing it between males on the left-hand side and females on the right. And then below that is, instead of looking at just the incidence or the occurrence of cancer, but actual deaths. So you'll notice at the top slide, both in the male, prostate is listed number 1, but many times we're diagnosed with prostate cancer, men are, and they don't die from that. So you'll see in the bottom list that while it still can cause death in people, it is below lung cancer. Lung cancer is the number 1 type of cancer with cause of death. Same with breast in women. In the top, you'll see that breast incidence is high, but deaths are number 2. And then colorectal is number 3 for all. And then you can see kind of the variety of different sites, both incidence and death that occurs. I'm going to go ahead to the next slide. This is an interesting graph because it is comparing both Black people versus US whites. And the darker color, or the red color, which is unfortunately, the one that is above the lighter colored one, which is the white in colors. And this is looking at actual death rates, so not incidence of cancer, but actual death rates. And if you look on the left-hand side, the top one is talking about males, and it says all sites. So it doesn't matter where the cancer is located. You can see that there's and then at the bottom, you'll see that that's years. So I don't know, it's kind of small, but I believe it goes to 2015, 16. And you can see that there is kind of a bell-shaped kind of curve. The good news is that we're all trending down from deaths from cancer, but there is a discrepancy between African males and white males. And then on the other side, the right side of that first box, it's looking at females, all sites. You notice that the incidence, or the rate per 100,000 is much lower in women for cancer than men. So just kind of looking from one side to the other. And in women that are Black, they still have a higher incidence of death than whites, but not quite as, the two curves aren't quite as far apart. Then we go down to the next set of graphs, as we still on the left-hand side, and it says lung and bronchus. And again, we're seeing that higher death rates in African American or Black men as opposed to white men. And women in general have a lower cause of death to be lung cancer. And it looks like the two lines are on top of one another there. So actually at the very end, Black women have a lower death rate from lung cancer. Now the next grouping is talking about colon and rectal cancer. Again, the one to the left is going to be the male, and the one to the right is going to be the women. So you'll see that initially Black men were lower than whites, and then as time went on, and even to the most recent data we have here, Blacks have a higher incidence of colon and rectal cancer, both in the men and the women, as you look at those two across one another. And then if you go down further, the prostate, that's quite a disparity there between African or Black males and white males. And then breast cancer, again, we see the lines initially together and now have separated. And we'll kind of go over some of the thoughts of why the lines aren't the same in the next couple of slides. So if you want to go forward. Okay, so why does this happen? So there's been a lot of talk about this and trying to figure out exactly why does this happen. Some of the reasons could be that there's a lack of quality healthcare. The access for Black people is less. Their health insurance may not be as good, or may not allow them to have the screening test or other test, or maybe treatment. There's possibility of discrimination by the healthcare providers themselves, maybe not giving them the care that they deserve. Education in general, we'll look at that as we go on, but education, the lower the education of a patient, the less likely they are to get as good a care. Housing is another possible problem. If we live in a lower income housing, there's more potential for toxic exposure. Then that also goes down to exposure to environmental pollutants, might be where the person works. There's also a fairly high rate of obesity in Black people over white people. And I did go and look a little bit more into that. And not only are Black people have a higher incidence of obesity, but the degree of obesity is much higher in the Black population, particularly women. They may not have as good an access to healthy foods, which can lead to the obesity. Exercise and sedentary lifestyles, we know for all people, can lead to a higher rate of cancer. There may be some genetic or biological reasons that Black people, just because of their genetics, have a higher risk. Particularly, we see this in breast cancer and certain subtypes of cancers. They also, in general, Black people are not as well represented in clinical trials. And that's the last reason that's listed there. So the next slide shows what men need to know about prostate cancer. And this is really kind of interesting that it's quite high, 5.3%. This is on the right-hand side. This is the top 10 causes of death in Black men over the age of 45. And the chance of being diagnosed with prostate cancer by age, you can see that as we age, in general, prostate cancer usually occurs in older men. So as a person gets older, there's a higher risk of them developing prostate cancer. So that's not too surprising, but the percentage of death is much higher in Black males. So we'll go forward. So how would someone know they had prostate cancer? Well, this is a list of symptoms that can be caused by prostate cancer, but there are many things that can cause these same symptoms. So particularly in men, as they age, they have difficulty with having to get up in the middle of the night and go to the bathroom, or they have to go to the bathroom more often. They may have difficulty starting the stream of the urine, or there may be some pain or burning when they urinate or pee. They can, the stream of the urine usually decreases with age. They may have difficulty obtaining an erection and decreased amount of fluid that comes out with that, or have a painful ejaculation. They may have blood either in the urine or in the semen. They could also experience pressure or pain in the rectum. And if we think about a prostate gland, as I said, it's not uncommon for men as they age. There's this condition called hypertrophy. But cancer, of course, as we all know, increases this number of cells and makes it enlarge too. So how do you know? Is it hypertrophy or is it cancer? So that's why it's sometimes difficult to know. There can be pain or stiffness in the low back, hips, pelvis, and thighs. Again, as that prostate enlarges, putting pressure on nerves. So those are some of the symptoms that can occur with anyone with prostate cancer, but also with other conditions. Next slide. So then there's quite a bit of controversy about this next test, which is a PSA. And PSA stands for prostate-specific antigen, and it's a blood test that we can run on men. And when I first was in medical school, we did it all the time. We ran it, and if it was elevated, that was a sign that possibly the man had prostate cancer. And if it was elevated, then we would send them to the urologist because it is elevated in prostate cancer. It began in 1994 is when we began screening for this as a screening test. And the hope was, by running this test, that we would find prostate cancer earlier and decrease the number of deaths. So go to the next slide. But here's what happened was that people that had an elevated PSA, it wasn't very specific. So it didn't mean necessarily they had prostate cancer. And there were a lot of non-cancerous conditions that can cause that PSA to elevate. And what we found out was that they ended up getting more biopsies and more procedures and more tests to have prostate cancer, and the yield of that testing was not uh, deemed adequate. So by some. So there is a controversy on whether or not to even run this test in men. So go ahead to the next slide. So screening offers a small chance to reduce a man's chance from dying from prostate cancer. As we saw earlier in the slides, prostate cancer, while it is one of the higher, is in the list, it's still not, a lot of people will die with their prostate cancer instead of dying from their prostate cancer. And screening led to a high number of what we call false positive results, meaning the test was positive, so we think you could have cancer, but when they actually did like biopsies or more testing done, the patients didn't have prostate cancer. And this was then thought that there was being too much biopsies, things were being done too aggressively, which resulted in overdiagnosis and overtreatment of these men. And anytime you have any type of procedure, whether it's a biopsy or a treatment, it can lead to complications. And in particularly for prostate gland, it can lead to incontinence, meaning that the man no longer can control his urine, or he may lose the ability to have an erection. So you can understand why we have to really take it seriously, and men take it seriously about having some type of treatment that they may not have needed, and yet they end up with one of these complications. Now, it's not all people that have these procedures have it. It's a small number, but it's still significant. So that's why there's this controversy about PSA testing. So why don't we go ahead to the next slide? So the USTA is a United States Preventative Task Force, and it kind of does a lot of telling physicians what kind of screening they recommend and what they don't recommend. And because there is this controversy over PSA, they are now saying that we need an individualized decision. So the men need to talk to their physicians and decide, well, if you have, like, let's say you have a family history of prostate cancer, that may be a strong motivator to get the PSA. And so that would be a reason that a doctor may say the benefits outweigh the risk or harm that can come from a false positive. The USTA also says men over the age of 70 don't need to continue to get a PSA level. The American Cancer Society says that men over the age of 50 that are over an average risk over and expected to live at least 10 more years. So instead of putting a number on when you stop, like 70, it's more about their health. So if you think a patient is going to live another 10 years, their health's pretty good, then you should continue screening. Again, you see that it's an individualized decision making is really what it should be, a conversation between the physician and the patient, whether or not to get the screening. And we can go ahead and go forward. So African-American men are considered at an increased risk for prostate cancer. So if I have this conversation with a Black man, I'm going to be more encouraging to get this test than I would a white man, because we know when we looked at those first set of slides that the amount of prostate cancer in Black men was much higher. So again, they need to talk about the risk and the benefits. If you know of any family history, such as a brother or a father or someone being diagnosed and treated for, or someone who's been has died in your family from prostate cancer, that would put it a much stronger suggestion. And you'll notice also that the American Cancer Society actually moves the age up. In the previous slides, when we were just considering all people, it said the age of 50 for men to get PSAs. But because Black men get prostate cancer earlier and it's more aggressive, in general, when we see prostate cancer earlier, whether it's Black or white, it tends to be more aggressive. But particularly in Black men, you may want to go ahead and get that PSA test. And you'll notice that if you have a really high risk, meaning a first degree relative, so that would be like, your dad or a brother, but not like an uncle or a cousin, that's a second degree relative, then you may want to even move that date from 45 to 40 to get your PSA. Again, the earlier we catch cancer, the less likely it's spread, the more likely that we can have a cure from our treatments. So that is the reason that the age, and because Black men can have a higher incidence earlier, we move that age of PSA testing up. So very important for anyone that is a Black male to consider getting PSA testing. Again, knowing the risk and benefit of that test, still they can have false positives too, which can lead to treatment that they didn't need. But again, it's always an individual decision with the physician. We could go ahead to the next slide. Now let's talk about women that are Black and what they need to know about breast cancer. Breast cancer is the second leading cause of death in women in the United States. And African American women under the age of 40 are more likely to develop breast cancer than a woman who is white and under the age of 40. And women who develop breast cancer, no matter Black or white, if they're younger the cancer, the more aggressive it tends to be. And particularly in Black women, there are some rare but more aggressive subtypes that are more difficult to treat. So again, getting it early is key. And let's go ahead to the next slide. So there are some risk factors for breast cancer that we can't control. In general, then people who get breast cancer are usually older people. So if we look at the numbers, just like for prostate cancer, older men get more prostate cancer. Same with breast cancer. Black, white, doesn't matter. There's still an increased risk with age. Now we all want to have more birthdays, so we can't change that. The density of the breast, that means how much of the breast is kind of fat or how much is glandular, fibrous. You may have heard of fibrocystic disease. That's not something we necessarily have control over. Obviously, we didn't pick our parents, so we don't have a family history of breast cancer we can't control. That also goes for genetic mutations. We may have had radiation. Women who have had radiation, maybe to treat another cancer or for some other reason, they're at a higher risk of developing breast cancer. Your menstrual cycle can have influences on the amount of estrogen you've been exposed to. So that has a risk on breast cancer. And then this chemical here at the bottom is actually a drug, DES, and it was given to pregnant women. And we have found that then those pregnant women's daughters actually have an increased risk of breast cancer. It was I think it was stopped in the 1971, that kind of range is when it was no longer given. And it was, given to help prevent pregnancy complications. But in the end, we found that it was a toxic drug and it's no longer given now. But still, there are those women that, while they were in their mother's womb, were exposed to this drug, and now they have an increased risk of breast cancer. So let's go forward. Breast cancer risks that you can control. Not being overweight or obese after menopause. That's one of the things I help people with at Iowa Cancer Specialist. I work with people to try to help them with lifestyle changes. So a lot of the things that are on this list are things that I help people with at the Cancer Center. Um, it's kind of biologically women do gain weight with menopause, but we can work on losing that weight and not being obese. Eating healthy and a balanced diet is also important. So even if we're normal weight, but we're not eating our vegetables and we're not eating healthy proteins, then that can be a risk factor as well. So really important to eat those vegetables. Grandma was right. Alcohol, it's interesting. Alcohol causes a change in the way that estrogen is metabolized. And the more alcohol you drink, the more toxic the estrogen can be metabolized. The liver is the main organ that detoxifies things in the body. And we all know that alcohol can affect the function of the liver. Physical activity, another, lots of interesting and great studies that show how important it is for us to move. And the more sedentary we are, the higher our risk for breast cancer as well as many other cancers. Birth control pills. Now, this one's a little more controversial again. There is a slight increase if we look at observational studies in breast cancer in women that have taken birth control pills. The problem with that is that, and it's birth control pills, not bills. The problem with that is that the observational studies are just that. We're just observing, and there's not clear correlation. So it's kind of a weaker association. Getting pregnant later in life or not at all is also a risk. And again, this has to be do with our exposure to estrogen. When we're pregnant, that cycling stops of the hormones. And it's thought that actually the cycling is part of the exposure to the estrogen is what causes increased risk. And then lastly, you'll see taking menopausal hormone therapy, like if you take estrogen and progesterone because you have hot flashes, there's again a thought that there's an increased risk potentially to develop breast cancer in those women. Again, we're taking more estrogen in, progesterone in, we know that some breast cancers display those receptors. So it's, again, controversy on that one as well. I've heard lots of different lectures about that. That's just something to consider. Go ahead to the next slide. Okay, so now here we're looking at breast cancer disparities. Black women are more likely to be diagnosed with breast cancer at a more advanced stage and experience delays in treatment. And despite similar incidences, meaning occurrences, of Black women are more likely to die of breast cancer than white women. There's a higher death rate among African American women, are likely due to factors such as the diagnosis of the cancer was in a later stage. They may have other illnesses other than cancer that contributed to it. And as we talked before, there's this higher obesity rate, particularly in Black women. Why does it matter that we have increased fat? Well, there's an enzyme called aromatase that is actually located in fat, and it can, again, make more estrogen metabolites that are priming the system for cancer to occur. So the less fat we have, that lowers that aromatase, And you might, if you have had the diagnosis of breast cancer and it's got estrogen receptor, then we often use aromatase inhibitors to treat it. So in addition, African American women have less access to high quality screening, diagnosis, and treatment of breast cancer. So let's go ahead and go forward. What are the most common symptoms of breast cancer? Obviously, if we feel a new mass or lump, and that it may or may not have pain associated with it. It could be tender, soft, or rounded. It could be have irregular edges. Other symptoms include swelling in a part of the breast. So not necessarily that you have a distinct lump, but you just feel a swelling. If the skin is irritated or dimpling, kind of looks like the cover of an orange, the orange peel, that same kind of texture, that would be a reason to have your breast examined. If you're having pain in the breast, if the nipple normally goes outward and all of a sudden starts turning inward, that's a sign that you need to have the breast examined. If there's redness or scaliness or thickening of the breast or breast tissue, that would be another reason. You can have infections that can cause that as well. Nipple discharge other than breast milk is something to be concerned about. Again, you can have nipple discharge with an infection too. And then swollen lymph nodes. So particularly in our armpits for breast cancer, that's where we kind of feel to see, because the lymph nodes, are part of our immune system. And so our cancer, wherever it is, if it leaves the breast, it'll first go to those lymph nodes. And that's our immune system trying to trap those cancer cells and kill them. So if you have swollen lymph nodes, again, a reason to be seen by your physician. I'm going to go ahead and go forward. Mammography is a best screening tool for breast cancer. Now, if we get a mammogram, it doesn't prevent us from getting a breast cancer. It helps us find that breast cancer early. So regular mammography does reduce a woman's risk of breast cancer by about 30%. Women who do regular mammograms, however, can still die from breast cancer because mammograms aren't perfect. Sometimes the cancers aren't seen on mammography, so even though there is a cancer there, and you get, typically it's every 1 to 2 years you get your mammography, and sometimes cancers go really fast. So it wasn't seen last year, but now is seen this year. And sometimes by the time it's seen on mammography, it's already spread to other parts of the body. So let's go forward. There's also breast cancer screening controversies, just like that PSA. Because again, when should we start screening? What age should we start? There's controversy about that. Sometimes we find more breast cancers, but maybe that breast cancer would have never done anything, or the body would have actually attacked it. We have our own immune system that takes care of cancers. So there's some concern that mammography is picking up overdiagnosing and leading to overtreatment. Maybe we see a mass, they may say, well, it could be cancer, and then we do more biopsies and we find out that it wasn't cancer. So this is an ongoing debate. It's been going on for decades about who should be mammographied, when, how often, all of those things, because there just really aren't clear answers about that. Let's go forward. So again, we have the American Cancer Society at the bottom telling us what the recommendations are for average risk, and then this USTA Preventative Service Task Force. So the USTA says women between the ages of 50 to 74 screening every other year. For women that are age 40 to 49, you should discuss the risk and benefits of screening with their doctor. If you're a woman whose mother or sister had breast cancer or a child developed breast cancer, you are at a higher risk. And therefore, you might want to not wait till you're 50 to have your first screening mammography. You would want to have it earlier. Now, when a patient has had breast cancer, we don't screen, we do, well, first few years, we do what we call diagnostic to make sure that you had the cancer removed. We'll do those yearly, usually, to make sure that no cancer has reoccurred or a new cancer hasn't developed. So that's different than a woman who has never had breast cancer. So when we talk about this screening, that is, people that haven't had breast cancer. You'll see the American Cancer Society says between 40 to 44 should start screening if they have a screening mammography every year, and 45 to 54 get mammography every year. And then after the age of 55 and older, then they can go to every 2 years. And again, instead of picking 74, they say it depends on your health. If you're healthy and you're 84 and you're going to, you could live, let's say you're going to live to 95, then you could still have one at 84 if you're expected to live 10 years or longer. And the reason, again, for that is that we don't want to do too many mammograms. Mammograms are radiation. We saw that as listed as one of the risk factors in developing breast cancer, but we have to kind of balance that. So that's why there's so much controversy over this. Let's go ahead to the next slide. Now, that was just kind of in general. But now we're going to look specifically at African American women. The American Cancer Society says there's a higher than average risk. If women have a higher than average risk, are those that have a strong family history of breast cancer, or if anyone in their family or they themselves have been tested for a BRCA mutation, that's a specific mutation that can lead to breast cancer, or if that patient has had chest radiation before the age of 30. Again, there's a fair number of people with maybe lymphoma that receive radiation to their chest, and they're at a higher risk. So those are the people we're going to put in the high risk. In those patients, we're going to recommend, in addition to a mammogram every year, an MRI. And it starts at the age of 30 if you are high risk. So again, I think just like it was for the PSA, I think it's really important to talk to your primary care provider about when to start screening. The American Cancer Society also recommends doing monthly breast exams starting at the age of 15, because we know there have been women that do identify their breast cancer on an exam. They may not even be due for a mammogram for another 6 months or a year. And if that's what you find, then we should do the screening. We should do a diagnostic mammogram if you do feel something you're concerned about, or at least have a provider examine it and say, oh no, that's nothing you need to worry about, a doctor determining that. So let's go ahead to the next slide then. All right, we're going to switch gears now to lung cancer. Again, we talked earlier that African Americans are diagnosed with lung cancer at higher rates than other races or ethnic groups in the United States. Look at the percentages there on the other side, 47 versus 64. And Black men are 15% more likely to get lung cancer than white men. But interestingly, Black women are diagnosed with lung cancer 14% less than white women. Isn't that interesting? I'm not exactly sure why that is. fascinating. Let's go ahead to the next slide. So in general, what are risks for lung cancer? Obviously, smoking. We all know that smoking increases our risk of developing lung cancer, but you also the secondhand smoke. So if your partner or your parent smokes and you're in, or you work in a smoky environment, then that can also increase your risk. Radon, which we do testing in our homes for, it's something we have in this area, can lead to an increased risk of lung cancer. Asbestos, if it's aerosolized, can cause increased risk. There's workplace exposures, both of asbestos and other types of chemicals that can lead to increased risk of lung cancer. If you live in an area that has higher air pollution, you have a higher risk of lung cancer. Arsenic in drinking water, higher risk of lung cancer. We've talked a couple of times about how radiation therapy can lead to a higher incidence of breast cancer, can also lead to higher incidence of lung cancer. And then if you've had a lung cancer before, or someone in your family has had lung cancer, that also increases your risk. Go ahead to the next slide. Now, symptoms of lung cancer. Again, these symptoms are not very specific. You know, we've all had a cough and that's one of the symptoms, but particularly for a person with lung cancer, it doesn't go away and it may be getting worse. Anytime you have a cough like that, you should probably be seen and evaluated. If you have pain in your chest, back, shoulders, unrelated to the coughing, that may be another indication. The change in the amount of mucus that you cough up, you'll see later on it says if there's any blood in that mucus, that would be a reason to be seen. Shortness of breath. We can have shortness of breath for lots of reasons, but it can also be a symptom of lung cancer. We can have changes in our voice, or the voice may be hoarse. That would be, again, that can happen with illnesses. It can happen for many, many reasons. If there's recurrent lung problems, such as infections like a bronchitis or pneumonia, and anytime you cough up blood, that's a reason that you should be evaluated. So you can see that unfortunately, the symptoms of lung cancer aren't very specific. We've all had some of these symptoms at one time or another. So that makes it hard. Let's go forward. So we do have lung cancer screening recommendations, and these are for primarily smokers. And we have developed low dose CT scans of the lungs, and it is recommended starting at age 55, again to the age of 80 for the USTA, to have this low dose CT every year, as long as you're still smoking, or up to 15 years after you quit smoking. And so you have to have smoked a certain amount, 30 pack per year. So 30 years of smoking, basically one pack of cigarettes, then you qualify. The American Cancer Society gives the age of 55 to 74 who have had at least a 30 pack per year. And you have to have, once you've quit over 15 years, you don't need to have a screening. And then in general, you need to be in good health to do the screening as well. So those are the recommendations for the lung cancer. Now for colorectal cancer, again, African Americans have the highest colorectal cancer incident, and also the mortality rate is much higher for African Americans than all other racial groups in the United States. You see there's close to 20,000 diagnosed in 2019, and it's the third most common cancer both in Black men and women. And the incident rates for colon cancers has decreased by 2.7% in Black males and 2.8 in Black women. But if we compare that to the rates in white men and women, you'll see that while it's decreased in both, it hasn't decreased as much in the Black population as it has in the whites. And let's go forward. Symptoms of colorectal cancer. Again, like a lot of cancers, they're not very specific. You can have blood in your stool. Well, if you have hemorrhoids, you can have blood in your stool. But that is always a reason to be evaluated. If your stools become very narrow, that's another possible symptom. Unexplained abdominal pain, unexplained change in bowel habits. If you develop anemia, particularly, that means you don't have enough red blood cells in your body. Particularly if it's an iron deficiency anemia, then we want to look at the colon. And unintentional weight loss. Those are also symptoms of colorectal cancer. Your risk of colorectal cancer goes up as we age. Pretty much most cancers, the risk goes up as we age. Risk factors for developing colon cancer are being obese and overweight. Again, that physical inactivity. Interesting, our diet really does make a difference in colon cancer. The higher meats and processed meats we eat, the higher the risk of cancer. Also, eating foods that are cooked at a high temperature, so that grilling or that blackening, frying, broiling, those all lead to increased risk of cancer. Smoking increases our risk of colon cancer. Heavy alcohol use. If we've had colorectal polyps, so one of the reasons we do these colonoscopies, which we'll be talking about, is to find these polyps. And polyps some polyps never do anything. Other polyps that you can find are what we call precancerous polyps, and they can grow and become a cancer. And one of the reasons we ask people to do colonoscopies is to try to find these precancerous polyps, because we have shown that if we remove those polyps, then they never do go on to develop cancer. So we can kind of prevent colon cancer. There are some people with a family history of developing a lot of polyps. There's a rare syndrome called Lynch syndrome. There's also familial adenomatous polyposis. It's genetically inherited. Those people have a higher risk of developing colon cancer. If you have inflammatory bowel disease like ulcerative colitis or Crohn's disease, they're at a higher risk for developing cancer. We know that inflammation in general leads to higher cancer risk, and in particular, inflammation in the bowel can lead to cancer. Having type 2 diabetes is also a risk factor for colon cancer. So again, here we're going to talk about screening tests. Remember, always with screening, we're just detecting it. We're not preventing, we're just detecting it early. Maybe here, if we're getting polyps out that are precancerous, we are preventing though. USDA says that we should do these colorectal screenings between the ages of 50 and 75. And they say between 76 to 85, it kind of depends on your overall health and your prior screening history when to stop getting colonoscopies. The American Cancer Society says screening should start earlier at the age of 45 for both men and women at average risk. The GI Endoscopy Association recommends 45 as well. So you see there's again some controversy on when do you start doing a colonoscopy. The types of screening and how they should be done. Again, it depends on you. Colonoscopy every 10 years. I guess there's some benefit to that. The whole colon is looked at, um, and you can remove those polyps if you find them. The CT scan, there's a virtual one that's done every 5 years. I'm not as familiar with that. I don't think that's something we do locally. But again, if it's a CT, you're using some form of radiation, which has some risk. A flexible sigmoidoscopy, that's where we just look at not the whole colon, but the end portion of the colon, and that's done every 5 years. Again, there are, double contrast barium enemas every 5 years. Not something we do here locally. That's again a radiology test where they're putting barium into your rectum and putting it up there and looking at the colon through an x-ray. There are some fecal immunochemical testing that can be done every year. We can look for blood in the stool. Again, colon cancer, one of the things you can sometimes find is blood in the stool. And then there's a stool DNA test that's done every 3 years. And so it depends on which test you get. Now, let's say you had a colonoscopy and you were found to have some of those precancerous polyps. Well, then you're not going to wait 10 years to have another colonoscopy because they're going to make sure that you don't have more polyps growing. So they're going to maybe recommend it in 3 to 5 years, depending on what they found. So again, it should be individualized. And again, a decision that you should make jointly with your provider, given your history, your thoughts, and the provider's thoughts. So we'll go forward then. Okay, so what's your action plan? One other thing that I would say about colon cancer before we go over this slide is that there also is good evidence that the more fiber we have in our diet, the healthier our colon is, and the less likely we are to have cancers. Again, I really think it's so important to focus on our food as medicine. And in general, in America, we have a very low fiber diet. We could not just for colon cancer, but even like estrogen metabolism, fiber binds the estrogen. So there are some things that we can do. And this is kind of what this is talking about. What is our action plan? How can we decrease our risk both from getting and dying from our cancers? First, to talk about cancer with your family. You know, I am not uncommonly, I'll talk to someone and they'll say, yeah, I don't know why mom or grandma died, and they really don't have a good family history. I think that there's some cultural things around that as well, you know, that people don't feel comfortable talking about cancer. Particularly women talking about breast cancer because the breast is considered a sexual organ. Men may also not feel comfortable talking about prostate cancer for that same reason. So I think if we can normalize that and show the importance of talking about cancer within your family, I think that can really help people. So know if you have a family history, find out if you can. Now, obviously, if you're adopted, that might not be something you'll know. If you smoke, of course, we're going to say quit. That's another thing we do at Iowa Cancer Specialist. We do some smoking cessation sessions with our patients. If you are a smoker, you want help quitting, we do it. The hospitals sometimes have programs. There's a quit line. Both Iowa and Illinois have a quit line. You can get free, sometimes medications depending on your insurance to help you quit smoking. It's just such a good thing to do, not just for reducing your cancer risk, but your heart. All kinds of things are improved with quitting smoking. And then I'm going to really like this next one, which is eating a healthy diet. So important for us to eat our vegetables, to have lower meat intake, less processed foods. Very important to decrease our risk of both getting and dying from cancer. And then finally, moving. It says exercise, but I think we really have to think about how little we move sometimes. And the more we can move, and now we have all these, fancy things like Fitbits and things like that, that you can count your steps and just try to move more, because again, decrease our risk and empowers us. So I think those are important parts of your action plan. We can go ahead to the next slide, and I just wonder if there's any questions or out there, and I'd be happy to, if I can, answer them.
Yeah, we don't have any questions on Facebook, but we do have a thank you and a comment that was great information. So thank you, Dr. Jager. And I think the next slides I can cover here.
Yep.
So let me make myself spotlight. Oop. All right. So I want to just talk about a couple of cancer support community things here. So this slide is about our cancer experience registry, which we've been talking about quite a bit here and there. And what it is it's an experience registry. So it is a survey that gets information from people impacted by cancer. So they have separate ones for caregivers and for people who are diagnosed with cancer or survivors. And it really gets to the issues that you face. And taking this survey and becoming part of this community really helps with educating the medical community. It's used for policy to guide programs like Cancer Support Community and Gilda's Club. So we know what things you're dealing with and how we can support you in those moments and improve quality of care. So if you're interested in helping with that, you can go to cancerexperienceregistry.org, or we actually have our own Gilda's Club one. I will post that in the comments. And you can kind of look through that and take the experience registry and become part of this information database that gets used for a lot of really important things. And if you take our evaluation, which there's a link in the description for this video, I think you can sign up to get that information, but I will also put the Gilda's Club Quad Cities link in the comments. And I also want to talk about our grassroots movement. So this is advocacy, which sounds like such a scary thing. It sounds like this big thing. But if you're interested in policy and advocacy, becoming part of our grassroots movement is a really great first step. It gives a lot of information about the big things that you can do to make a difference and the little things. Anything that you can do to advocate on behalf of cancer patients and their loved ones. There are big things, little things, they all make a huge difference. And here is our phone number, Gilda's Club Quad Cities. Again, we are a cancer support community open to anyone impacted by cancer. So that's the person with a diagnosis, the loved ones, the kids, and we have all kinds of programs going virtually right now. There's our phone number and our email address, and our website is gildasclubqc.org. And this is our program partner. So thank you everyone for joining us on Facebook, and I hope you have a great night. Thanks, Dr. Jager.
Oh, it's fun. Thank you. I think we should get involved in those advocacy groups for this disparity we see for our African-American people. It just shouldn't be that way. Or for low economics, which is also something that wasn't presented in here, but is also on the American Cancer website, talks about how people with lower economic status can have a higher death rate, those things. And I just wish in our country that wasn't something we were facing. So I think
Absolutely.
That's a great place to get involved. I think, just this last year, all the things that we've seen, the craziness, those of us who really want to promote community and spirit gosh, this is a great way we could take that first step and have Gilda's Club support you. So I think that's a really cool thing.
Yeah, absolutely.
Yeah.
Well, thank you everyone on Facebook. I'm going to stop the live stream and have a great night.